I think we have some really promising treatment de-escalation for HPV-associated cancers, but our major barrier remains as to how do we choose the appropriate patients for de-escalation with the goal of maintaining cure and decreasing morbidity. And currently, we're using just the size of the tumor and the number of lymph nodes and whether or not somebody is a smoker, or we're treating patients with induction chemotherapy or with surgery, and then based on their response or the pathology, determining who can be de-escalated. And I think we need better markers for de-escalation. So there are some markers that are currently being validated in a prospective trial. And I'll just tell you about a couple of those. There's some genomic markers that predict outcome. There's two genes in particular called TRAF3 and CYLD that are regulatories of inflammatory signaling, and they're currently undergoing validation. And I'll just show you a little of the data that led to this trial. This is from TCGA, and it shows that tumors in red who had mutations in these two genes had better survival than HPV-associated tumors that lacked mutations in these genes. And without getting into a lot of details, basically defects in these genes identified two separate subtypes of HPV-associated cancers with many, many differences molecularly, as well as this survival difference. And so the idea now is, can these markers identify patients who can be de-escalated? So I'd like to just summarize about de-escalation therapy for HPV-associated head and neck cancer. I really think it holds great promise, and we need to do something to have our patients' quality of life improved after treatment. We want to decrease the morbidity of therapy. We want to maintain good cure rates. And something I haven't mentioned is we want to improve cure rates for those patients who are not going to do well with the standard therapy, which may mean new therapies are needed. And we want to improve quality of life for our patients. So we want to take this and turn it into this: smaller radiation, smaller chemotherapy, minimal surgery, or perhaps new drugs. The challenge still remains how to appropriately identify patients who will do well with this de-escalated therapy. So with that, I'll close, and I appreciate the time to explain a little bit about where we're heading with de-escalated therapy for HPV-associated head and neck cancers.